everybody. On behalf of the Pediatric Hematology Oncology chapter, I welcome all of you for this International Cancer Day special webinar. So, as you all know, that Childhood Cancer Day is a global collaborative campaign to raise the awareness about childhood cancer and to express support for children and adolescents with cancer, the survivors, and their families. So, this day promotes increased appreciation and deeper understanding of issues and challenges relevant to childhood cancer and impacting on the children, adolescents with cancer, the survivors, their families, and the society as a whole. So, this annual day was created in 2002 by CCI, which is a global network of 183 parent organizations, and now it is celebrated across the world. So it's a very important day, and it has brought all of us together. And on behalf of PHO chapter, I welcome all of you once again, and I welcome our distinguished guest, Dr. Carlos. So, Dr. Banavli, if you could please introduce our distinguished speaker for today.
Great. Hi, Carlos. Hello. Yeah, good morning.
Hello.
Good morning to you. And welcome all our colleagues from India. So, basically, I have the great privilege and honor of introducing Carlos. So, Carlos Rodriguez Galindo serves as the director of St. Jude's Global and chair of the Department of Global Pediatric Medicine. He is also the executive vice president and holds 4 stars of Chicago Endowed Chair in International Pediatric Research. Basically, all this you can get from the net, so I don't want to go into that. But Carlos and we were together. We are from the same batch of fellows at St. Jude's in 1994. And very importantly, though many of us who were doing the fellowship, went back to our respective countries and with the aim of or the short vision of trying to improve the outcome of children with cancer in our respective countries. Actually, Carlos stayed back. He's from Spain, actually. He's done his pediatrics from Spain, and he came along with us. Like I came from India, he came from Spain to St. Jude's to do the fellowship in pediatric hemato-oncology. So we went back, but he, with a great vision of improving not only the outcome of children with cancer in his country, he wanted to improve the outcome of children with cancer worldwide. And with that broad vision, actually stayed back in the US, and now he's working for so many years, mostly in St. Jude's. For a short time, he was at Harvard also, but he's come back and he's working at St. Jude's since 2015 now as the director of St. Jude's Global and chair of the Department of Global Pediatric Medicine. So he has done a lot of work in this short few years. He has really brought the pediatric oncology community across the world together, and he has a great vision of not only improving the outcome through research, but also basic things like the providing drugs, getting us together, and taking care of the low hanging fruits like ALL and retinoblastoma wilms like diseases, bringing together, improving the overall outcome from what it is now to at least doubling it in the next few years. So he's along with the WHO and UICC. They also have a global initiative in childhood cancer. And I'm again happy to say that I was, associated with Dr. Harvey Price, with Dr. Ian McGrath way back, who was the INCTR person who also had the same vision. And now, Dr. Carlos is taking it forward. And hopefully, in the next few years, we'll see the improvement in outcome of children with cancer, not only in developed countries, but also in developing countries. And today we are lucky to have him, on this important day, address us or talk to us about curing childhood cancers and curing children with cancers, inequalities, and access to childhood cancer care and control. So over to you, Dr. Carlos, and hope I may have a little bit in between. I may be out of it, but I'll join again after some time. Thank you, Carlos, for agreeing. And this is our first, as our the present EB. This is the first meeting, international meeting. So thank you for being part of it.
Well, thank you so much, Manas and Shripad, and thank you, all of you friends in India. I see many faces and names that I know for many years. So it's a pleasure for me to be here celebrating the International Childhood Cancer Day with you. I'm starting the day, you're finishing the day. And so in between, I hope that we all pediatric oncologists and advocates for children with cancer around the world have come together to continue to fight for the children that we care for. So thank you again. I will share my screen now, if you allow me. And so hopefully over the next, say, 40 minutes or so, I can share with you a few thoughts of initiatives that are happening at a global level and and how St. Jude as an institution, our program, are trying to make our contribution working with partners around the world, with the World Health Organization, so that we can create a little bit of path that we all can walk. And so I start by saying that I honor all the work that the Indian Academy of Pediatrics and the Pediatric Hemonc chapter have done in India, which is amazing. I really admire the work that is happening right now or has been happening for many years in India. Please know that from St. Jude, we are big admirers of all the work that you do. So thank you so much for inspiring us. So let me start with this. So every year, approximately 400,000 children develop cancer. That means that today, International Childhood Cancer Day, more than 1,000 children will develop cancer just in the hour that we're going to be talking about childhood cancer. Probably around 30 or 35 or almost 40 children will die of cancer, whether they are in Egypt or in Guatemala or in Myanmar or in India. Every minute a child is suffering, every minute a child may be dying or suffering ready for those end of life. And so I think that we can agree that there is one truth that if we want to cure childhood cancer as a community, if we say that we are curing childhood cancer, we need to cure the children that suffer cancer. And these are two separate constructs. As a scientific society, we advance a lot for in the care of childhood cancer. We know more how to treat leukemias, how to use CAR T cells, how to optimize treatment for brain tumors. And here at St. Jude, maybe 90% of children that come for treatment can be cured, but this is not the reality around the world. And so the roadmap towards this global response for childhood cancer has accelerated over the last 20 years, I would say. And I would just like to start with this moment, maybe at the beginning of this century, with the United Nations Millennium Development Goals, the MDGs, with MDG 4 aiming to reduce under 5 mortality rates by 2/3 over the next 15 years. And we did a lot of work as a community. So the mortality rate for children under 5 has been cut by more than half since 1990. And this leads to what you see on the right, which is a model or more or less what we expect. So from left to right, you have under-resourced countries and high-resource settings. In blue, you have the reported incidence of childhood cancer. And as you know, the reported incidence of childhood cancer is twice as high in North America as it is in Western Africa. In red, you see the under 5 mortality rates, very high in Western Africa, very low in North America. And so there is this virtual, if you wish, moment when as countries move from left to right, the under 5 mortality rates drop. And then the reported incidence of cancer, probably because the competing risks of death are resolved, increases. And so it's an expected epidemiological transition that we see all over the world, that you see in India, in the different states. But then in green, you see the cancer-related deaths. So the number of children that die of cancer, and these are a polynomial curve. So it's low in Western Africa because children die of other things, of diarrhea, of infections, of malnutrition. It's low in North America because we can cure childhood cancer. The problem is as countries move from left to right, the incidence, the prevalence of childhood cancer increases and countries are not ready to manage that. That's why we see this increase in mortality or in cancer-related deaths as countries move from left to right. And so this is a way to place a focus so that we can help government, we can help states in India, for example, to accelerate that process as childhood cancer becomes a problem. And so this is the landscape worldwide. So in the left, you see the reality. The reality is that about 400,000 children develop cancer every year, but only about 200,000 get diagnosed. So there is already 200,000 children that die without even being diagnosed. On the right, you see the cost of inaction. If we don't do anything over this next decade, this gap will continue to increase. And over the next 3 decades, there will be about 14 million children developing cancer, and 6 million of them will die undiagnosed. And this is, when we put it all together, is the current survival rates across the world. So if we put together this, the lack of diagnosis, the children that die without diagnosis, those that get diagnosed but don't have access to good care, less than 30% of children with cancer survive around the world. So we are not much different from when St. Jude opened its doors in 1962, where less than 30% of children survive. So around the world, we haven't made much progress. So what is the problem in trying to prioritize childhood cancer? I think that we all understand that childhood cancer is not a public health issue. So at a country level, at a political level, we need to address communicable diseases first, and that's reasonably so. So we need to prioritize vaccination and prophylaxis, sanitation, clean water. Then non-communicable diseases become a priority, but it's usually the most prevalent chronic heart conditions, cardiovascular diseases, diabetes, or obesity, then it's cancer, and then childhood cancer. But there are ways of trying to bring the dialogue about childhood cancer up in that priority list. For example, this is a work that we did with Lisa Force when she was a fellow. Now she's at IHME in the University of Washington, looking at childhood cancer burden from a different perspective. If we look at childhood cancer burden as DALYs, disability adjusted life years, so the years of life lost, and we compare childhood cancer with the most common cancers of humans, including all the adult cancers, childhood cancer as a burden is number 6 in the world. If you look at the right side of the table, in low and low middle income countries, actually childhood cancer is number 1, the number 1 cancer in DALYs in terms of disability adjusted life years. So it's a good way to reframe our dialogues when we talk with governments or with other funding agencies. When we said, cancer is rare, childhood cancer is rare, but actually, if you think about the future that is lost by not investing in childhood cancer, this is actually the most prevalent cancer, if you wish. And so when we start talking about this language, about costing and cost effectiveness, we have already optimized this calculation. So this work that we did with the Lancet Oncology that some of you were part of. But so we have been able to calculate how much it costs to take care of a child with cancer. So whether it's in Ghana, El Salvador, Mexico, or even the United States, it takes about 6 to 7 times GDP per capita to take care of a child with cancer. So it's predictable. This means that we can include this in our budgets, for example, and we know how long it takes. But most importantly, when we look at cost effectiveness, and cost effectiveness is measured based on cost per DALY averted, disability adjusted life years that we have gained by that investment, childhood cancer is very cost effective, somewhere between cost effective and very cost effective because of its cost per DALY averted. And when we talk about cost effectiveness and costing, and this is important as we bring this topic to the governments, to the state governments, the country governments, it's important also then to highlight, and I summarize this slide with just what you see at the bottom. If you think about, the productivity gains that we can calculate by investing in childhood cancer today by a local government in India, you can tell that there will be a $3 for every dollar invested in this scale up as these children survive and enter productivity years. So there is a way of telling that there is a net benefit in the investment on childhood cancer, which is not the same for adults with cancer, as you can imagine. So I think that these are pearls that we can use as we engage with the decision makers in our hospitals, in our governments, in our states. So this is the problem. So the cure rates for childhood cancer are now above 80% with modern therapies and supportive care. However, as we have seen, about 400,000 children develop cancer worldwide, and more than 80% of these children live in countries with limited resources. So the global cure rates are much lower than what we have been saying. So most of children with cancer in the world die, and yet sustainable, as we have seen, and cost-effective models are possible. And today we're talking about childhood cancer. We're not talking about catastrophic blood diseases like sickle cell disease, thalassemia, or hemophilia, but the similar disparities occur for those children and those diseases. And so starting in the last decade, so the world has moved forward with some of these concepts. And so I would like to start by highlighting some of these time points. One is in May of 2017, just 6 years ago or 7 years ago, when the WHO, through the World Health Assembly, declared cancer as a priority with a cancer resolution, for a call to action for governments to come up with plans for sustainable care of people with cancer of all ages. So we accelerated that in the childhood cancer community in 2018 by just launching that global initiative for childhood cancer together with the World Health Organization. This, as you know, was presented in September of 2018 at the high-level meeting for non-communicable diseases of the United Nations. And that was in 2018. And in 2023, just 5 years later, that was last fall, we celebrated 5 years of this initiative in the same scenario at the United Nations General Assembly. And so I'm going to summarize this in a couple of slides. So the World Health Organization Global Initiative for Childhood Cancer basically aims to achieve through the cure-all package at least 60% survival for children with cancer globally through these 3 pillars and 4 pillars and 3 enablers. So, aiming at centers of excellence, universal health coverage, creating a consensus for regimens of management, and then putting systems for evaluation and monitoring. But then with these enablers, advocacy, financing, and policies and governance. And so most countries, most programs or states work on what have been defined as the actionable core projects that address these 4 pillars and 3 enablers. And so it's a guidance through the cure-all package on how to do it by starting with a good analysis of the cancer health systems, developing national cancer control strategies, implementing workforce training packages, developing pathways, defining the standards and guidelines, creating a path for essential medicines, economic analysis and benefit packages for universal health coverage, developing cancer registries, then developing good systems for monitoring, and then regional advocacy portfolios so that there is proper campaigns and engagement of the civil society. So the cure-all package brings together some of these concepts in a ready-to-use model. And so the WHO Global Initiative for Childhood Cancer, as you know, has brought many countries on board, including India. Now 74 countries are engaged from this top-down approach at a government level, trying to address that and bringing all the stakeholders. And they're at different stages, and as deep dive focused countries, or countries with some activities, or countries in dialogue. But they are is part of the journey towards full embracement of the compromises of the Global Initiative for Childhood Cancer. And so some easy or quick case studies. So the 2 of the first focus countries, Philippines and Peru, for example, in the first couple of years, advanced laws that really protected children with cancer and their families from the financial toxicity of cancer in the Philippines, preparing a package for care in Peru, also adding a package for support of the parents that actually had to take off work while taking care of the children. And so with a financial compensation, if you wish, so that there would be family stability and minimize the financial toxicity. So these are two quick examples of how through the GICC, governments are embracing and changing policies to advance towards that care. I want to say that these are models that hopefully many more countries are currently following as well. So how St. Jude how are we from St. Jude trying to address that? So I'm trying to put this picture, and Shripad reflected as well on some of us came to St. Jude at the time in the 1990s. I hope that still today was like a mecca for many of us, a place where a dream was possible, a place where, we started fighting for childhood cancer and we have never stopped. And so that was how St. Jude was in 1962, where it opened its doors, a small star-shaped hospital. And this on the right is Danny Thomas, the founder and entertainer, who said that no child should die in the dawn of life. And St. Jude is a not-for-profit organization. Patients don't pay anything. We bring the patients here for care as a charity hospital, but mixed with research and advancement in care. And so we started in 1962. We had an international outreach program for many years, but we accelerated this process in 2016 with the foundation of the Department of Global Pediatric Medicine, which is a think tank, if you wish, to generate the knowledge to advance care globally. That led eventually to a strategic plan that 2 years later led to what we call the St. Jude Global, which is that commitment at the institutional level to ensure that every child with cancer or catastrophic diseases have access to quality care. And then through the St. Jude Alliance, in partnership with partners that we work with, created the St. Jude Global Alliance, and St. Jude is one of the members of the alliance, and we'll describe that a little bit more later. And some of institutions in India are members of this alliance. And then in this journey, we started working with WHO. We're a bottom-up organization working with hospitals, but it's important to work always at the top down with governments. And so in March of 2018, we became a collaborating center for childhood cancer, and that's basically to provide technical support to the WHO. But through that, as you know, we helped create the Global Initiative for Childhood Cancer, which we fund. So we still do today. We provide the funding that the WHO needs to implement the GICC, but we are not involved in the management of the GICC. It's an independent project by WHO with our financial support, and that led to the Cure-All package. But so in this process, we also signed partnerships and engagement with other global agencies, IAEA to advance radiation therapy and diagnostics, IARC to advance cancer registration and burden estimation, with UNICEF and the Pan American Health Organization. So this is St. Jude Global with this mission that I have described to improve the survival rates for children with catastrophic diseases worldwide, with this vision that every child should have access to quality care. And we work in these 4 pillars: how to build capacity, how to educate and address the workforce gaps, how to do that while we're generating evidence, that is research, and then how we can do that as well by engaging advocates and mobilizing resources. And so as a hospital, we are committed to where the patients are, like all of you. And so we are physicians working with physicians, aiming to optimize the care for that child at the center of everything. And that means that we need to influence, like all of us here in this session, how the hospitals work, improving the care that this child receives. But to do that, we also need to work at a country level, improving policies, referral networks, mobilizing resources, but also at the regional level because of that solidarity, that leveraging of resources, working together, but then creating a new world, a new movement, a new way of understanding childhood cancer. And so to touch the life of that child at the center of everything, we just need to go through these 4 layers. It's impossible. It's impossible. It's the only way we think of maximizing the care for this child is by just creating strategies that change the world, that improve capacity at the regional level, that work with governments, and finally, that can change how a hospital takes care of that child. And so the St. Jude Global Program tries to work on strategy in each one of those four levels at different capacity. And so this is the St. Jude Global Alliance that I mentioned, with many institutions in India that are part of the St. Jude Global Alliance, which is more than 200 partners, hospitals and foundations in more than 80 countries that organically come into different regional programs. But the idea is just to leverage resources, bring ideas to the table, and then advance care together. So we have what we call the transversal programs, which are basically ways of trying to create homogeneous packages, whether it's in nursing or in critical care or infection or palliative care. This is how we define ourselves. So we are complete when we are together, because it takes all of us to take care of children with cancer. It takes a village to take care of a child with cancer, as we say. So it takes a global village to take care of all the children with cancer. And so a few words about what we do to address the workforce. As the WHO says, there is one universal truth, that there is no health without a workforce, and there are huge gaps, as you very well know, that you are trying to address as well through your academy. And this is what we try to do as well through our St. Jude Global Academy. And so we have several components. One is the Global Professional Education Program, with clinical training programs, distance learning, training seminars, as you know, Cure for Kids. So we have these three categories. We are relaunching Cure for Kids. You are familiar with Cure for Kids. We are migrating to a new online website that will be very exciting, because it's much more modern, newer content, self-paced, more interactive. We have as well what we call the training seminars, which are competency-based education programs in a hybrid structure, with distance learning, with modules, but then experiential learning, that then after 4 or 5 months, usually it's either at St. Jude or in other parts of the world, then the participants just come together for behavioral change. That is how we're going to be moving forward. Usually it lasts between 3 and 6 months, and we do about 5 or 6 of these courses per year. And so then we have the clinical training programs, which is 2 to 3 year fellowship training programs in regions where there is a need, for example, in Central America or in Sub-Saharan Africa or in the Middle East. So we create a 2 or 3 year program in partnership with an existing academic institution, and then we create the structure, the curriculum, the syllabus for that, and then we try to bring trainees from the region to graduate from that. And so we have a contract with ACGME for proper accreditation. And so anyway, so that's a good way, and we do something similar as well for critical care, for palliative care, and for nursing. And then we have the Global Scholars Program. We have several scholars from India as well, as you know. And this is done with our graduate school, and it's a master's in global child health. It's a 2-year competency-based degree in global child health, with health systems innovation concepts, epidemiology, political economy, global health, and policy. And so as these graduates have finalized their training, they can have their global projects funded. And there are a few projects in India currently, and that's a 2-year funded project to implement. It's less clinical, it's more about systems, about changing and strengthening the health systems. Then a capacity building. When we talk capacity building, we talk about big things, but at the end of the day, we need a process for that. And for us, capacity building, it's more than just build capacity in a hospital. It's addressing the health systems, addressing health inequities, developing evidence-based therapies, or creating nursing standards, or infection control, or quality improvement. Everything that goes from making a policy to administering chemotherapy or antibiotics to a child, or providing palliative care or psychosocial support to the family, is building capacity for us. So when we started working about 5 years ago, we thought we need to develop a method for that. And so you're familiar, some of you, with this adaptation framework that we kind of tried to create through the SJ Cares conceptually is like a PDSA cycle, right? So think about the intervention, monitor the outcomes, assess quality, and then intervene and just repeat, right? So we started with these questions. How might we contextualize childhood cancer treatment? How might we systematically and efficiently monitor the burden and the outcomes and create a roadmap for improvement? And how might we design and scale up interventions, strengthen the health systems, influence policies to make it all happen? And so we created, as you know, three kind of research innovation think tanks, one led by Nikhil, another by Paul, another by Kath, that you all know very well. And so with the disease burden and simulation, we created the global registry and the ARIA guide that you are familiar with. Through the metrics and performance, we created Profile, which is this 360-degree evaluation tool, and the global packages. And then through the health systems unit, we created two additional tools, systems and policies, and all comes together in this slide. The consensus ARIA guide, actually the steering committee is meeting right now while we're having this call, that it's basically about creating evidence-based adapted guidelines for everything from supportive care to cancer treatment, the global registry, the profile tool to assess infrastructure, capacity, and quality, the global packages, which are these QI, implementation science packages that are kind of almost off the shelf to address, and then all together with the systems and policies. And so many of you are familiar with that, so I'm not going into too much detail about this, but happy to continue the discussion if you are more interested. And then research. I wanted to bring this today because you are also a research community, and so as a pediatric oncology community. And so we realized how much we need to do. There are no evidence-based practices. We don't have good structured processes or methodologies, and we need to define all these priorities. So I wanted to share in maybe 3 minutes some examples of collaborative research that we do through the Sanju Global Alliance. One is what Paola is doing with the MAS, the Mexican Alliance with Sanju Group in Mexico. Another one, what Asia Gulnik from our critical care program with the early warning scores. And then what Dr. Pui does in China. So the first one is the group in Mexico. The problem that the group in Mexico, as they started to come together, was trying to address was a high treatment-related mortality with less than 30% of patients receiving antibiotics in the first hour after presenting with fever and neutropenia. So the question was, how might we improve rates of administration of antibiotics during the first hour, decrease sepsis, and improve outcomes by something as basic as that? And so the methodology that was used was quality improvement. And so we partnered with IHI, Institute for Healthcare Improvement. We have a quality improvement, group here, almost like a mini institute. And so in this slide, I summarize the work of many years from the inception to prototyping to then test of scale and then sustainability and then the full scale, and how we use quality improvement methods to do this PDSA cycle. And in that process, we train, you see the many people from nurses to doctors to residents to emergency room doctors in this process, more than 500 people training quality improvement. And so creating coaches, creating path for improvement. And here you see the work in 2 years in the first 85 hospitals, increasing compliance with antibiotic administration, the time to administration of antibiotics from 47% to 79%. So that's a 68% increase. And then a 61% reduction in sepsis from 15% to 6%. And so this is a real example of how to use basic research methodology like quality improvement. Then the Proyecto EVAD is early warning scores in a similar model. So we also realized that there was not a good way to optimize care for the hospitalized children that were at high risk of clinical deterioration. You all experienced that, we all experienced that. A child with cancer treatment, with fever, for example, is at risk of very rapid deterioration. So how might we apply a resource-adapted PEWS, pediatric early warning score systems, for early detection of deterioration and immediate intervention when you have less nurses, you have less capacity. So can we adapt an early warning scores and implement it? And so for that, the methodology that we use was implementation science. So you are very familiar with the Pew's scoring tool and the Pew's algorithm that is based on vital signs, but also the nursing and the family concern. The nurses score at every single vital signs checkup. And then based on the score, there is an algorithm that tells we need to close observation of this patient. We're okay, we need to call the doctor, we need to send the patient to intensive care. So the first thing that we had to do is to translate it into Spanish, modified to the resources that were in one unit, and we selected Guatemala, and then validated. Can these modifications still predict a deterioration? And that was the first step in this implementation process. So this then was implemented, and yes, first we were able to validate and were able to decrease the deterioration events. We reduced the PQ utilization, we improved communication and staff development, and we also showed that by investing in that, we actually saved the institution $350,000 in 1 year by decreasing the resources, the utilization of resources in the critical care unit. So once we showed that, then we went to a scale up that took over 5 years or 4 years. And so from that center in Guatemala, then we started expanding, and you see 99 centers in 20 countries in different cohorts that have been implementing these over waves, right? And there is an implementation methodology for that. And so now if you go to Latin America, even in the countries with the least resources, like in Haiti, that you see here in the middle, you see that all the children in the childhood cancer units have the score. And so the score can be a color marker or a magnet or whatnot. But regardless of the resources, all children have to go through the early warning score system. And so through this implementation science methodology with multiple implementation waves, we were able to train more than 16,000 clinicians, more than 300,000 patient days were impacted. We improved communication. We decreased the clinical deterioration event mortality by 25%. But most importantly, or also importantly, we changed hospital practice beyond childhood cancer ward because many other units started adopting the early warning scores. So quality improvement and implementation science are good anchors for collaborative research because they bring together not just the researchers, it's the entire unit, it's the entire team, not the 2 or 3 investigators that put together a protocol. It brings the nurses, the physicians, the nurse administrators, the unit managers, the people that answer the phones that need to actually call the pharmacy to get the antibiotic. And then at the highest level of clinical research complexity, we have then, through our global efforts as well, engaged in that clinical trial design. And that's, very well, Dr. Pui. And so with his engagement with China, was able to put together a major ALL study group with 26 major medical centers covering more than 70% of the population, and also showing that it was possible to then bring that large number of institutions and patients into a clinical trial that then showed that actually with some modified therapies, you could cure 90% of children with the standard risk ALL. Also in China, moving from 30 to 40% to almost 90% in less than a decade. So for us, research is the entire continuum. It's about developing evidence, whether it's quality improvement, implementation science, or clinical trials. And then think that it's not only about intervention. As we do that, we need to think as well about the non-interventional research, population sciences, for example, in medical anthropology, and we do some studies as well on medical anthropology and patient communication, but epidemiology as well, or even etiological research. So it's our community, the global community, that needs to be engaged purposefully in this research model. And so I have shown with you a little bit our microsystem approach. Our microsystem is working at the hospital level through this QI, implementation science, education, engagement. But then we have realized that by working at a hospital level, when we are very purposeful, and then we start bringing multiple institutions together, as you have seen, we start influencing the meso level, multi-site projects. The community starts working together. And then as this movement starts, we can influence the macro level. When we have a critical mass participation, we develop evidence, but then we build trust with the decision makers so the policies can change because they feel that there is a community that will carry this forward, and that's the pediatric oncology community. And so some of the examples that I have shown, like the EVAD or the Golden Hour, were incorporated by the Pan-American Health Organization, the WHO of the Americas, at the government level as part of the packages that PAHO implements through government engagement. So this is our model from the hospital, and I said these 4 layers, right? Going to the hospital, but from the micro level to the system-wide effort and back. And so we need to learn how to pivot from one level to the other level and how to learn from one to the other. And so I realized that because we started a little late, I may just go to accelerate and stop at some point when I realized that we need to stop. But I wanted to highlight with you as well at this micro to macro level, how that has taken us as well to work at this global level. So as I mentioned earlier, we're a collaborating center for WHO. As a technical collaborating center, we provide support with national cancer control plans, support in diffusion of cancer management, research and education, or technical support with training materials and stakeholder engagement. And so, as I mentioned, we provide that support from behind, just trying to make sure the WHO has the resources to implement that. And so through that, WHO has been able to create that structure within the WHO with personnel at the headquarters and regional offices that you have people also in India that are dedicated to childhood cancer care and control. So we also provide support at that level with this initiative that we call policies, and that's part of the SJ Cares, led by Catherine Lamb, that you know very well. And Kat, as the director of our cancer, WHO Collaborating Cancer Center, and also as director of our health systems unit, has put together a lot of resources that you may want to use as well, like the policy monitor with more than 1,000 policies that are searchable, that can be used by governments or by providers to do an analytical input into policies at the country level. And so that is used as a resource that Kath puts together then to develop what she calls the NCCP Digest, basically at a country level, put a brief, a document with the policies that could work, a policy snapshot, and then a guide on how to facilitate dialogue at the government level. But then Kath also has put together something that is very interesting, which is that NCCP ICAIA, or Integrating Children, Adolescents, and Young Adults, which basically it's a training program, a series of seminars that walk stakeholders from government and other organizations through this process. As you know, many countries lack NCCPs. Ministries do not typically engage pediatric oncology teams in the development of their cancer programs. And so we need to prioritize children in the national cancer control plans. So we developed this policy science-driven workshop series that it's 6 parts with 4 UN languages, with country case studies, lessons learned, and resources. So we're starting now the second class of that. So the first class had applicants for more than 50 countries. So we asked the teams to come as a team, as a ministry-led team, bringing stakeholders, pediatric oncologists, government officials, administrators, etc. And so over 6 months, we completed this process with 17 countries, more than 30 cities represented, more than 100 participants, policymakers, case studies, etc. And so at the end of this process, each team had to come up with their package in terms of a development of an integrated national cancer control plan. So the resources that I shared about St. Jude with the SJ Cares, a set of tools, basically you can see how they all integrate into the core projects that we put through Cure-All. So there is a bunch of resources that St. Jude can provide and countries that are engaged in the Cure-All framework. And Kath keeps a dashboard that can be consulted of engagement by countries and programs, so that can be consulted at any time, and that helps programs understand where they are in that journey. And so if you allow me 5 minutes, I will try to finish that. We started with this picture of the children that every single minute around the world are, and their families are going through diagnosis and treatment and support. And so there are two big elephants in the room, as we know. One is diagnostics. I started by saying that more than 50% of the children don't even get diagnosed, and that those that get diagnosed, about 20–30% don't have the correct diagnosis, as we know, because of lack of resources. And the second big elephant is the medications. As we all know, there are shortages and problems with medication quality. So I want to share two big initiatives that we are doing. One is this global platform for access to childhood cancer medicines that we're doing with WHO, UNICEF, and the PAHO, Pan American Health Organization Strategic Fund. So we know the problems with medications. I don't have to reiterate that, about availability, about quality, and about cost. And so if we create a global platform, how could this platform help? And so the idea is that it would improve access to quality chemotherapy for children with cancer, and pardon that typo there. And so it would improve the quality by, investing on reliable manufacturers. It improve the affordability by creating effective pricing approaches and reducing out-of-pocket costs. It would improve availability by having proper forecasting and a rapid response system and tracking, and then improve accessibility because there will be multiple facilities participating. So this is the vision of this platform, to provide this comprehensive solution. We started with a $200 million commitment from St. Jude over the next 5 years. Doesn't mean that it's only St. Jude. It's just that we want that proof of concept, and hopefully other funders will come, governments or other organizations, to grow that platform with a phased approach over the next 6 years, with a development phase that is being finalized, and 2 years of piloting the system in up to 12 countries, 2 per WHO region, and then a growth phase that could affect more than 50,000 children per year. So if we can get in 5 years up to these 50,000 per year by 2027, hopefully we'll be able to impact 120,000 children by that time. This is how that's global governance, with a secretariat at the World Health Organization that oversees all these operations, a procurement agency that is UNICEF, and the PAHO Strategic Fund for the Americas that will be responsible for the purchasing, quality control, registration at a country level, tracking and distribution. And that would be the procurement agency working with manufacturers and the recipients. And then with the governance structure is completed with a steering committee, technical and community advisory board, and then the donors. Right now St. Jude, but hopefully there will be a multi-donor trust created in the future. This is where we are right now, very simple. We're about to launch this pilot phase in the summer, probably in July. And so about 8–10 months ago, we had we convened the 6 first pilot countries here in Memphis for this last mile, process mapping. As you can imagine, one thing is to bring the medications into the country. A very different thing is to making sure that these medications can follow the proper process for registration and distribution, and they reach the patient that are intended to. So we did this exercise with Nepal, with Ecuador, Jordan, Mongolia, Zambia, and Uzbekistan, which are the first countries that were selected by governments and WHO to start that. And so hopefully this could create a model that hopefully will be implemented over the next decade and expand to beyond cancer into supportive care, medications, and others. And the other big elephant in the room is the diagnostic gap. So in any of our centers, to get an example, for example, a leukemia, we need to have a clinical staging and diagnosis, a phenotype, macrogenetic, and then molecular. But now we know that at the end, what we rely on is the lineage and genomic subtype for proper risk allocation and treatment. This is an initiative led by your good friend, Nikhil Bhakta. But in many countries and with resource-limited labs, we don't have that middle part. So we go from phenotype, and that it's immunohistochemistry, sometimes flow to a treatment. And oftentimes we don't know if it's an ALL or an AML, if it's a lymphoma, or it's even a rhabdomyosarcoma. So the question is, can we just fast forward in a leapfrog and go straight to the lineage and genomic subtype? And this is basically what we're trying to do, is just try to go quick into that end stage. So genomic sequencing that can be performed in a resource-limited setting through different sequencing platforms. And then the question, as you know, is not so much the sequencing proper, but the analytics. And so the analytics is provided through cloud computing. And so the idea is that at the bedside, we can do the sequencing that is at the institution. Then the cloud computing would provide a very reliable diagnosis. And that's what we call DIVIA, this diagnostic innovation with usually we are testing Illumina Nanopore, the DIVIA portal that actually brings that computing capacity and provide the diagnosis within a 24, 48 hours. And that will be sequencing an RNA-seq for leukemias, and will be methylation profiling for solid malignancies that we can complement then with the registry. So you have, if you wish, the entire package for burden estimation, diagnosis, and outcomes. And so we're starting that in the next couple of months, and actually 2 institutions in India, as you very well know, many of you know, will be part of this pilot phase, and hopefully we can then support additional expansion in India. So I want to end now. I am just on the hour, and I'm sorry about that, but we can spend another 5 minutes if you wish, with this slide that we produced for the Lancet Oncology Commission. And the point of this slide is that we need to provide comprehensive scale-up packages. So if we address just abandonment, just drugs, just access to care, the number of lives that we can save is limited. However, if we put the entire package, a comprehensive scale-up, we can save many more lives. And that's what you see in the survival probability in purple. And this is the value chain that we try to conceptualize. So these are all the steps that need to happen for a child to be cured. We need to find that child, refer that child to the institution. We need to make the right diagnosis. We need to treat that child appropriately. We need to have good quality medications and quality of care. And so we have tried, through the presentation I shared with you, some of the pieces that we have tried to put into this puzzle, from the Cure All packages with WHO, the policies and systems, the DIVIA platform that I share with you for diagnosis, the ARIA guide, the medicines platform, and then all the initiatives that we do at the bedside, from registry packages, profile, training, etc. Then how through the Sanju Global Alliance we try to all work together in defining this. So that's my last slide. So we started with discussing this epidemiological transition with improvements in maternal and child health services. And as countries progress through the MDG and the SDG goals, we see an increase in the burden of childhood cancer and catastrophic diseases. And these advances in the global health agenda have created this unique opportunity to accelerate progress. So that means that we have an imperative, our generation, to develop accurate, sustainable, and scalable plans. And so this is our challenge, that we can decrease the global disparities and share the progress that we have made in advancing cures for children with cancer to all children all over the world, so that this is for every child and this is everywhere. And I want to give credit to all the leaders in the Sanju Global and the department that actually have done everything that you have seen in these slides and that work with you in many different capacities. So thanks so much, and sorry for the snap at the beginning, and sorry that it took extra time. So happy to spend a few minutes, and if you have any additional questions.
Thank you, Carlos. And looks like you are really fulfilling the dream of Danny Thomas, who at that time wanted to cure not children of America only, but all over the world. Thank you.
Thank you, Dr. Carlos.
Thomas, if you can take over.
Yeah, thank you, Dr. Carlos, for this wonderful session. And it is just an eye opener, for all of us to see what St. Jude and St. Jude Global Alliance is doing for children with cancer across the world. So this is, I think, very moving to kind of imagine that this one institution is doing so much for children whom this institution is not even connected with, and how WHO is partnering with you to take this whole process forward. So I think what we all would like to know is also, and you can call me a bit selfish, or maybe an advocate for India, but how where do you and your entire platform and team uh, you know place India into this whole scene? And I understand that we are not really at the bottom of this whole system of the services in pediatric oncology, but we actually are like 1/6 of the childhood cancer of the entire world. So where is India in this whole picture? And what do we get from you, if you call me an advocate or a selfish person from that point of view? But I would want to know your thoughts about that.
Oh, thank you so much, Manas. I want you to know, and everyone, that India is in our heart. It's constantly in our brain, and because we learn so much from India, we are humbled by all the work that you do in India. And as you know, we have been engaged at an institutional level with some of the programs in India. We have been also helping advise as you created this Indian Childhood Cancer Initiative in response to the WHO call. And all of the above, from working with some of the institutions to working at this ICCI level, we offer our help here. And so whether it's some of the tools that we have developed that are very practical and that India can use, some of our guidance as well. And I would love, and we have talked with many of you, would love to be more involved in that level, just providing the tools, the response that you, as the leaders of the Indian childhood cancer community, might want from us, right? So, and we're very happy to continue this conversation at many different levels. And so, I would love to see that we find good opportunities for us to work together, not only for us to provide tools for India to use. No, it's not about that. It's just that we always like to engage in this one-to-one dialogue, right? And so I think India has a great opportunity to help as well the world with innovative approaches, how to maximize the implementation of projects. So I hope that we can, and we are already working on this. So definitely count on us to be more engaged and be whatever you need us to be. Yeah.
So, Carlos, this drug quality has been a big challenge for us in India. And with the generics and the cost being so less, we are always tempted to use them for our patients. So, you kind of highlighted that drug quality is a very important subject in your whole model of, what you're doing for childhood cancer. So, how will that be actually done at the ground level? Because that has been a very big challenge for Indian patients.
Yeah. So this is that's one of the areas where I think that, for example, a good deep dive in collaboration and thinking would be great. So when we tried to put together this global platform was a proof of concept. And as you realized, if you counted the 6 countries, that are small countries with just a couple of centers, 3 centers maximum, so that we could test whether it was possible to do a pool procurement for the country, do proper forecasting and distribution. And so it has worked well. I can tell you that we completed the tender. And of course, all the pharmaceutical companies that apply have to be pre-approved through, different regulatory oversight committees by UNICEF and WHO. There, there are many Indian companies that are part of that system. And so we see that there has been a good response by these pharmaceutical companies. We need to see now if it's possible to scale up and really provide the volume that it will be required. Now, a country as big as India could make a major impact by optimizing this model. Whether you can come up or we can come up with a unique model for India that would be very interesting, or whether the model uses the same, the WHO, UNICEF model. The volumes are huge, so there will be. I would love to talk more about how now what we have learned from the global platform could be incorporated in India. Whether India comes on board as one of the next countries in the next couple of years or 3 years, or if there is a need to develop a separate model just because of the volume in India.
So, there are a lot of compliments flowing in the chat box. So, Dr. Revati has asked, what is the specific recommendation for India with your experience? So, if you could just say that, and maybe get wind up after that.
Yes, no, I don't think I have a good recommendation. India, you all are guiding the world right now over the last years about how you organize ourselves, how quickly India is advancing towards those goals. I think that you have great um, structures through the Indian Academy of Pediatrics chapter in pediatric hematology oncology, the INFOC with a clinical trial structure, the ICCI working at a top-down level, trying to organize all the stakeholders. You are already on that track, and I think that if you look, say, 5 years back and you look 5 years in the future, I th- you know I think you should be very proud about all the work that has been done. Yeah.
So thank you, Carlos, and thank you for taking time out for the IAP PHO chapter, and doing this great talk for us on a very busy day for you. It's going to be a super hectic day with so many things happening in your hospital and everywhere else. So, sir, do you want to just conclude?
Yeah, yeah. So thank you, Carlos, and we gave you a head start for the hectic day today. But we hope and we know that we will be working closely and overall, trying to see how we can improve the outcome of children with cancer, not only in India, but at least help you out with the other developing countries. So thank you once again and hope to see you in India in March.
Yes.
Bye. Thank you,
Thank you so
Carlos.
much.
Thank you. Thank you, everyone.
Thank you,
Thank you,
everyone.
everyone, for
Have a great-
joining. Thank you.
Okay. Thank you.
Thank
Bye-bye.
you.
Bye.